Hello everybody, this is Sword Cameron, and today we're talking about infection with regard to the brain. We have a 30-year-old patient presenting with headache. They're found to have a opacification of their sphenoid sinus. It's important in cases of sinus opacification to check the adjacent soft tissues and review reformats in different windows. Here in blood windows we have a convex collection along the planum sphenoidale, and we also have on soft tissue windows abnormal material within the right orbit, fat stranding within the posterior aspect of the right orbit. Both of these are very suspicious for spread of infection, and an MRI would be recommended to better evaluate the extent of disease. Look for other complications as well. Here we have coronal T2, ADC, post-contrast coronal T1, fat saturation. Again, we see this epidural collection along the planum sphenoidale. We can see the abnormal edema within the right orbit. The collection restricts diffusion, and there is associated abnormal pachymeningeal enhancement. We see this smooth, abnormal, thick enhancement of the dura, pachymeningeal enhancement. We also see abnormal enhancement extending along the sulci, which would be along into the arachnoid space, which would be compatible with meningitis. So we have sphenoid sinus disease resulting in an epidural empyema with pachymeningeal enhancement and associated meningitis. In this young child, a different patient with frontal sinus opacification again, if you look carefully at these images, particularly this image on the right, we see abnormal material extending along the falx. Again, reformats can be very helpful as we see this abnormal mass effect in the region of the falx. The falx is actually bowed to the right. Now, because this is extending along the falx, we know that this is a subdural collection, not epidural. In any case, we have abnormal opacification of a sinus with adjacent intracranial extension, so therefore we have to get an MRI to look at the extent of disease. And MRI here clearly shows a very extensive subdural empyema. We have axial T1, axial flare, axial T1, post-contrast, axial T2, diffusion, and ADC. The material extending along the falx restricts diffusion and demonstrates marginal enhancement. There's also abnormal flare signal within the sulci and abnormal enhancement within the sulci greater on the left. So we have a subdural empyema and meningitis, and we also have abnormal parenchymal T2 prolongation and local mass effect. This turns out to be a focal cerebritis. Now, left untreated, this will turn into an abscess. Here we have an example of a frontal sinus infection with anterior soft tissue spread rather than intracranial. This would present as a mass clinically. Note the dehiscence of the sinus anteriorly. The eponym associated with this finding is Pott's puffy tumor, because it looks like a tumor clinically. Again, we see in a different patient this subdural empyema, abnormal enhancing material extending along the falx and in a crescentic shape along the anterior cranial fossa. Associated in that material restricts diffusion. Associated with this, again, we have abnormal parenchymal edema and mass effect. This would be a subdural empyema and cerebritis. this case is more advanced. We have another different patient with frontal sinus disease and a mass within the frontal lobe. Now this mass is not a tumor, as we'll discuss. On the axial T2, axial flare, axial T1 post, and diffusion weighted sequence, we have a peripheral rim of dark T2 signal surrounding local mass effect and T2 prolongation, ring enhancement with central non-enhancing restricted diffusion, and the material in the sinus also restricts diffusion. So we have a ring enhancing mass within the left frontal lobe with central non-enhancing restricted diffusion. This is clearly an abscess. Now the central non-enhancing restricted diffusion differentiates this from metastatic disease or primary neoplasm, which would have peripheral restricted diffusion of the enhancing portion. Here's a different case. In this case, we don't have sinus disease, but we have two different sites of abnormal ring enhancing masses with central restricted diffusion of the non-enhancing portions. We also have an SWI, which demonstrates susceptibility related signal loss, not related to blood products, but related to the bacterial cells. Whenever you see abscesses within the head, especially when it's clear that it's hematogenous spread, not direct extension, you want to think about the teeth. You want to think about a dental etiology with hematogenous spread and ask the clinician, what do their teeth look like? And if you have imaging of the teeth, review that as far as partially imaged maxilla or mandible on MRI or CT, because this can be helpful as identifying the source and treating that source. These infections, when they're dental, tend to be polymicrobial and have to be treated as such. Here we have a more subtle case, an older patient with altered mental status, specifically somnolence. This is a subtle finding, but very important to review this on all your imaging. And if you look at the posterior parts of the lateral ventricles, the occipital horns of the lateral ventricles, we see abnormal material, which demonstrates attenuation slightly above that of gray matter, almost at a gray matter. When we see this, we want to think about differentials such as pus, abnormal bacterial cells in the ventricular system, tumor cells such as leukemia, or blood products. This turned out to be a case of infectious ventriculitis. And on MRI, we see abnormal restricted diffusion, layering in the same place we saw it on CT, and corresponding T2 prolongation on FLAIR. Now, hemorrhage and tumor cells can have a similar appearance, and lumbar puncture is essential, as in all these cases. Our last case, I want to touch on a different type of disease, but also a form of encephalitis. Here we have abnormal flare signal and mass effect within the mesial right temporal lobe, the right insula, and the right cingulate gyrus, without much going on the left. So this is unilateral, but this process can be bilateral, and often is. This entity can restrict diffusion, it can cause gyroform enhancement later, and this is limbic encephalitis. Now the key entity to be concerned about in these cases is HSV, a viral or other viral encephalitis, and it needs to be treated rapidly as that as soon as possible. So as in all these cases, you need to call the clinician right away and tell them this needs to be treated right away, and then lumbar puncture should be done for confirmation of the exact etiology. Limbic encephalitis as a broad category can be caused by an autoimmune process or as a paraneoplastic process. If no viral etiology is found, then search for a primary neoplasm as a perineoplastic process is necessary. So today we talked about direct and hematogenous spread of infection. You want to evaluate adjacent to sinus disease, both in the soft tissues, the fat surrounding the sinuses, the orbits, and the calvareal compartments. We talked about the different compartments of infection as far as epidural, subdural, meningitis, cerebritis, encephalitis, and ventriculitis. We talked about the appearance of abscess with a dark rim of T2 hypointensity, but most importantly, central restricted diffusion, which is non-enhancing. And then we talked about limbic encephalitis as well. Thank you all for your time. Have a good day.